Good morning, everyone, and welcome to the Children's Hospital Genomics Roundtable. I'm Garrett Sheets, the content specialist for Genomenon, and I'll be moderating today's conversation. Today, we are excited to host a highly experienced group of panelists from 4 leading pediatric hospitals who will share their perspectives on recent developments and current practices within the realm of clinical and research genomics, as well as describe how AI-based tools, including Genomenon's Mastermind genomic search engine, are streamlining patient care and forwarding the collective effort to advance genomic discovery. They have a lot of great information to share, so I'll mention a small housekeeping item and then move right into our introductions so that we can get started. We have a really full agenda today, and for those watching, we want to be able to take all of your questions. If we don't have time to answer them at the end, we will send them to the panelists after the event and post them on our website. So without any further ado, I'll briefly introduce our speakers. Amy Treese is a pediatric and molecular pathologist and serves as the medical director of Molecular Diagnostics Laboratory at Children's Hospital Colorado. Also from Children's Colorado is Elisa Gaskell, who is the co-chair and scientific director of Precision Medicine, with expertise in the development and implementation of next-generation sequencing technologies and the analysis of genomic data. Elise Fiala is a senior genetic counselor at Memorial Sloan Kettering Cancer Center, with a focus on pediatric patient care. We also have Michael Walsh from Memorial Sloan Kettering, who is a pediatrician, geneticist, and hematologist oncologist. From Nationwide Children's Hospital, we have Roshani Abraham, the Associate Chief of Academic Affairs and Founding Director of the Diagnostic Immunology Laboratory in the Department of Pathology and Laboratory Medicine. Also from Nationwide is Elizabeth Varga, the Director of Clinical Genomics Research and Development at the Steve and Cindy Rasmussen Institute for Genomic Medicine. From St. Jude Children's Research Hospital is Kim Nichols, a pediatric oncologist and director of the Cancer Predisposition Program. Her research interests include the molecular mechanisms that provide protection against viral infections and cancer. Jamie Machasik is a clinical variant scientist in the Department of Pathology at St. Jude Children's Hospital. A trained biomedical engineer, her research experience includes the molecular mechanisms of sickle cell disease and pediatric T-cell acute lymphoblastic leukemia. Finally, Mark Keel is the founder and CSO of Genomenon, where he supervises the scientific direction of the Mastermind suite of software tools. His research interests include stem cell biology, genomic profiling of hematopoietic malignancies, and clinical bioinformatics. Mark, I'll open up the floor to you for a moment here. Did you want to say a few words to welcome our panelists?
Yes, sure. Thank you, Garrett. I want to welcome both the panelists. I feel very privileged to have assembled so many folks from the clinical front lines, as well as to welcome our audience members. And the very brief introductory remarks I want to give is just to say that we at Genomenon really appreciate the time that you're taking out to attend this discussion. I, as a panelist, hope to learn much more than I speak in this event. And without further ado, Garrett, I'll pass it over to you to begin the discussion so that we maximize the conversation time.
Perfect. Thanks, Mark. What a stellar group we have. And now that everyone has been introduced, I want to start with the team from Children's Colorado. And Amy, maybe you can speak to this. In terms of genomic healthcare for your organization, what are some, would you say, are some key initiatives?
Yeah, so one of the important things to know about Children's Hospital Colorado is that our approach to genomics currently is very clinically oriented. And so one of the big things that our institution is working on is a precision medicine service line. And the goal of this service line is to combine clinical, laboratory, and operational expertise to really help make clinical genomics available to all disciplines. And now that we see genomics really expanding into a lot of subspecialties beyond genetics, we want to make sure that those specialties have the same access to genomics. And so with this initiative, there's a major emphasis on infrastructure to help support patient access to testing, access to counseling, and access to treatment. And the goal is to really have a consolidated approach to issues that cross specialties so that we don't see efforts duplicated in various different silos. And so under this model, oncology, genetics, and other specialties are all at the same table discussing their needs and identifying areas that they overlap and areas of really high priority for the institution. And so through this approach, though this approach is really clinical, the service lines will also focus on how to leverage our clinical data to support research initiatives as well.
Thank you, Amy, for that. What else? Maybe someone from Nationwide, maybe. What are some comments on some key initiatives for your organization, and how do they relate to what was just shared?
Yeah, I'll take that one. So very similarly to the objectives at Children's Colorado, we started the Institute for Genomic Medicine about 5 years ago at Nationwide Children's, and the goal is to bring the research clinical operation together under one umbrella. So instead of being siloed with clinical laboratory testing and a separate research operation, we have the ability to perform research genetic testing, such as right now whole exome sequencing, but also some more research-based assays like RNA sequencing, methylation testing, and other specialty tests within the operation of research, but also confirm that clinically so that results can be delivered to patients across the institution. And very much like Amy, we are trying to really expand our infrastructure so that it's not siloed and increasingly incorporate into specialties, which one example of that is Roshani operating in immunology and kind of bringing some of the next generation sequencing technologies into other areas of care.
Thank you, Liz. So you mentioned, Roshani's work in immunology. Roshani, I don't know if you could give us kind of an overview about, how your work relates to, what has been shared.
So my focus is in the inborn areas of immunity, and where I came to Nationwide Children's from Mayo Clinic, and while I was at Mayo, I developed the targeted gene panels for the inborn areas of immunity. And what I rapidly realized is that we've now got over 450 different genetic disorders that fall under the umbrella of the inborn areas of immunity. And when I started the process several years ago at Mayo, I realized with the targeted panels, you need a sort of nimble approach, to stay up to date and, keep your panels all updated. When I came to Nationwide Children's, I decided that it would not be reasonable to recreate targeted panels for the inborn areas of immunity, because there were commercial reference labs that were doing a far better job and probably able to be more nimble and stay current. So we now focus, we send targeted gene panels outside, but when it comes to exome or even genome under the research umbrella, then we look within our institution to sort of tease out complex patients with immunological disorders.
Thank you, Roshani. So I guess, we've talked about kind of how these affect patients, and I think I'd like to shift the conversation to look at, trends. So I'll pose the question, and I'll kind of open this up to everyone. How is the approach to diagnosing rare disease and/or pediatric cancer kind of changed in the past 5 years? How about someone from St. Jude Children's?
Sure. Can you hear me okay?
Yes.
Yeah. So actually, I was going to mention too, in terms of our initiative. So I think this is a good segue. And let me talk briefly about what we have at St. Jude, and then I'll just talk about how it's changed. But so St. Jude, as many of you know, it's had a really long history in terms of doing research, genomics, and cancer through the Pediatric Cancer Genome Project. And 6 years ago, I was really fortunate to be recruited to St. Jude to bring on, a clinical genomics initiative where now we can offer all newly diagnosed cancer patients at St. Jude the opportunity to have their tumors evaluated using whole genome, whole exome, and RNA sequencing. And we can also look at their germline using whole genome and whole exome. I mean, that said, right, we are primarily a cancer institute studying, cancer and other disorders of the blood. So our focus is primarily on the cancer genes and, cancer risk genes. But I think that what's really wonderful about St. Jude is that in addition to providing this now as a clinical service, the data that's generated, right, as long as patients sign a research consent, both the tumor and the germline data, gets uploaded through the St. Jude cloud, which is a tremendous, research resource for institutions all over the world. So I just want people to know that they can access germline and tumor genomic data free of charge. And I think now there are, I don't even know, there are probably 10 to 15 or 20,000, genomes, including both tumor and germline in the cloud that people can access. So I think this has had a tremendous impact, right, on our ability to refine diagnosis of cancers, right? You can think about leukemia at St. Jude. I mean, through Charles Mulligan now, what we used to look at under the microscope. I mean, I've been doing pediatric oncology for 20 years, and I remember when I started, right? You looked under the microscope. Mike probably knows this, and you see a lymphoblast, and a lymphoblast was a lymphoblast, and everybody got ALL therapy. But now, thanks to genomic advances, I mean, there are multiple subtypes of leukemia, and some of them do better than others, and we know we need to adjust therapies based on some of these molecular findings. So I think, from a tumor perspective, genomics and precision medicine has made a tremendous impact, particularly in this case for leukemia. But we have a lot of work yet to do for many of the solid tumors, for example, and for some of the brain tumors. So I think, we're just at the tip of the iceberg. So from the tumor perspective,
Oh, we lost Kim's audio.
Yeah, I think we lost.
Okay, I'll pick up on where Kim, we lost your audio, but as a hematopathologist by training, one of my professors spoke to the obsolescence of the microscope in a similar way to what you talked about. I don't know that would be obsolescence, but it would actually be the augmentation with molecular diagnoses. And I was struck by how the WHO, the hematopathologic diagnosis in the WHO, was increasingly molecularly predicated. And as I was leaving my training, seeing that come in solid tumors and brain tumors as well. So I don't know how much more that's flourished since my training, but it was a very encouraging thing for me to see where the diagnoses become much more molecularly predicated.
Really good discussion. I'm curious to hear, I don't think we had any feedback from team members at Memorial Sloan. I don't know if Elise or Dr. Walsh, if you have anything to add on kind of to build on what has been shared so far.
Yeah, no, I think I would agree with what the others have said, and I allow Elise to chime in here as well. I think that we are, kind of as Kim said, at the tip of the iceberg, and I don't foresee necessarily other aspects of diagnosis going anywhere too soon, because I think there's so much variation of uncertainty that all of the additional information that we've relied on historically continues to be relevant in different ways. And on the germline side, as opposed to maybe just the tumor side, that is probably more so true, as we are dealing with so much variation of uncertain significance. And being able to phenotype and characterize tumors helps us better understand some of the predispositions as well, and the spectrums that go with a lot of the cancer predisposing syndromes. But yeah, I think we're still early days with a lot of this stuff, and we have moved though nicely, I think, from one of our original papers 5 years, 6 or 7, 8 years ago, to where we were describing a lot of the genetic predisposition, to more recently how we're really actually translating this clinically.
I'd like to quickly add to that. I think something that I've seen change here in the past 5 years is that our genetic counselors on the oncology side are involved from the very beginning of diagnosis of oncology patients. They attend our tumor boards, and these discussions of predispositions happen right at the very beginning of diagnosis and not as an afterthought or a follow-up. And so they're utilizing molecular results as soon as possible to get those patients plugged into predisposition clinics.
Yeah, and I was going to chime in one thing. I'm sorry about the audio. And this builds on what Mike said. I mean, in the old days, the whatever, 20 years ago, a lot of guidance regarding germline genetic testing was based on basically family history or patient medical phenotype. But now we're learning that a lot of families don't have a positive family history, or patients with specific syndromes, Fanconi anemia as an example, a good proportion of them don't have clinical manifestations. So having the ability to do genetic testing a little more broadly has, I really think, enhanced our ability to make germline diagnoses.
Okay, so we've had a really good conversation about germline variants. We've talked about trends that you all have seen in practice over the past 5 years. I'd like to now kind of look forward and ask you, kind of pose again generally to everyone, because we had such a great conversation, just kind of having everyone chime in there. How do you think, this approach to diagnosing, rare disease and pediatric cancer, looking forward the next 5 years, what do you see looking forward?
So I can take that one. And really it builds on everything that we've discussed to date, that I think what we will see is merging of fields and breakdown of the silos. It's very comfortable to think of something as inherited germline or kind of acquired mutation, but I think the more we're seeing, and even moving into the transcriptional space, we're learning so much, and we're actually seeing that there's more of a blending. So I think just as our tests are becoming unbiased, I think we should be approaching the diseases in a very unbiased fashion, and just know that we have the expertise, and based on the molecular profile, guide our patients through our system, rather than having just very solid paths into our system.
If I may add to that, in the inborn areas of immunity, I think a particular challenge is the number of new genetic defects we're adding to the list, so we're at 450, 460 now, and every 2 years there's an expert panel that gets together to classify all the inborn areas of immunity, and they publish that classification. And in January 2020, the biannual classification was published, and then 10 months later we have to have an interim update because we've got about 30 new genes added. So we can't wait for another 2 years to update the classification. And so I think for clinicians, it's exceedingly hard to sort of keep abreast of all these new genetic defects and the phenotypic variability. And then, of course, clinicians often are faced with the conundrum of these variants of uncertain significance, and, trying to do the correlation to the immunological phenotype, trying to do functional validation. So I think in the immunology community, that's something that we have to really work hard at. And we have a few sort of thoughts and initiatives around that. How do we functionally validate these new variants or new genetic defects, and how do we make sure that our community of clinical immunologists, but also hematologists, rheumatologists, anybody who sees patients with these inborn errors of immunity, how do we make sure that they are able to stay abreast of all this new information? So that's the challenge for the next 5 years, I think, for us.
Yes, I absolutely agree. Roshani, I think this goes across all conditions and, for many of the new genes. And as you think about it, it's super exciting as we discover new genes linked to various diseases. Often those may be, 1 or 2 families that bring these new genes to light. But the problem then is that there's very little published information about the genes and the genetic variants. So really knowing, as new variants are identified, are these truly pathogenic or not pathogenic, is very challenging. So I think, it's interesting, as we learn more, the number of questions is exponentially increasing, and, we're really going to have to work together as a community to standardize, how we define changes, define conditions, define phenotypes, and, put all of our information together to better understand, what these new variants are going to mean. So I just second you very strongly. I think it's a great time, but a very challenging time moving forward.
I wonder if I could ask. Oh, go ahead, Elise. You can go ahead, Elise.
Oh, sorry. So I was just going to say on the same lines that better defining the outcomes of screening now that we've brought in so much who's getting predisposition screening. You know, the families who are told that they have LFS today is so different from the families who were told that they had it 15 years ago. Like, it's such a broader group, and that's probably true for a lot of conditions, but LFS just stands out in that regard. And you know, we have like the Toronto paper that showed the outcomes of that screening, but I just don't think that the population even looks the same as when they started that study. And so as the population is constantly evolving, like, we don't know the outcome, and that's only one condition that we really have like a controlled study for. So I think the more and more we're all growing our surveillance clinics, and the more and more people we have in it, the more we need to then publish the outcomes of, like, did we even make a difference with all of this? You know, like, what was kind of all of this for? What were the findings? What were the false positives? What were the true positives? Like, what the outcomes look like.
I was actually going to use the same exact example as Elise with respect to TP53 and Leber-Meany syndrome. You know, with more and more unbiased testing and unbiased screening, we are seeing people that in families that just have one cancer type, they don't have the full LFS spectrum. And I mean, in terms of surveillance, is the whole body MRI every 6 months, every year really necessary? So there has been some conversation, which I think will inform diagnosis about expanding that phenotype, or having Leber-Meany and TP53 hereditary cancer phenotype. So as more and more people have unbiased screening and the phenotypic spectrum expands, that's going to also influence diagnosis and guidelines.
And Mark, I think you were going to say something.
Yeah, I was just going to build on what Kim and Roshani had brought up about the functional studies around confirming the pathogenicity of some of these variants, and then what Elise and Jamie had talked about, these larger scale clinical screens, and blending those two data sets together. My original question was going to be around functional screening across entire genes, and how much emphasis could be placed in taking a variant of uncertain significance with that functional evidence to suggest that there's consequences at the protein level. Is there enough evidence from those studies to promote a variant from the VUS to likely pathogenic within the ACMG framework? I just wonder, again, if it's outside of a single very focused paper about those variants, if it's the result of a screen, is that evidence sufficient for diagnostic purposes? And put it to the group broadly.
I don't have an answer, but I just want to say I think that that's a super important question. And if you think about it, it means you really need to understand what the function of every specific protein is, right? Some proteins have multiple functions, and there are functional, quote unquote, functional assays that you can do, right, to look at message, stability of message, or a transcriptional assay for a reporter assay for a transcription factor. But a lot of these proteins have multiple functions, and I don't know the answer, but it's a philosophical question. If a transcription factor doesn't function properly in a reporter assay, is that sufficient to call it a loss of function mutation? And honestly, I don't know the answer. I would love to know what others in the group think. I mean, it's one piece of evidence, but how much weight do you put on that evidence? Is that enough to convince you? And then, of course, right, there's 20-odd thousand genes across the genome. We don't know the functions of all of those. Developing one standardized functional assay that will apply to every gene in the genome is just not going to happen. So, how are we going to address this? This is something I've been contemplating since I moved to St. Jude, and I don't have an answer, but I would accept any suggestions.
I agree completely with Kim, and I think recently there have been some papers on inborn errors of immunity predisposing to severe COVID disease, and without giving all the information away, because some of it is just about to be published, but people have said, X or Y or maybe 10 other genes. If you've got variants in those genes, they predispose to severe manifestations of COVID, and then they cherry pick and do certain biochemical analyses, but then they forget to do that with variants in the controls. And then, you know, you're reading a paper that has all this information and you're saying, well, theoretically, they've done some functional validation of their variants, but because they haven't done it in their controls, you know, how are we to interpret that data? You know, so there is one issue, the design of your population genetic studies, and then the issue of the functional validation. And I agree with Kim. I mean, Kim knows all too well the challenges with the inborn areas of immunity, because we're just, you know, like mushrooms in wet grass. You know, we're just sprouting new genes all the time. And I didn't know the answer, Kim, either, because, you know, we're using a sort of a hodgepodge of methods and so on, but as we're getting to gene and variant curation, some of the gaps and the holes are becoming glaringly apparent, and we're now finding ourselves sort of soft pedaling or being more cautious about how we're interpreting and trying to introduce some caveats. But yeah, I think it is a challenge, because at least from the immune system perspective, we've just got too much variety to come up with some sort of facile answers of how to do the functional validation. I have to admit, Kim, I'm also strapped.
On the cancer side, it's nice in the sense that I think we're learning and being more creative about the way that we integrate the omic testing. But from both the somatic, germline, transcriptome, methylation testing, and trying to understand how we might be able to appreciate a second hit, how splicing might be better interpreted through different assays. So I think that on the cancer side, there's a lot of tools that we're now availing of in a more meaningful way as we're getting beyond the initial steps of just describing frequency and of variants and honing in on certain genes in a more meaningful way as we think about them. The functional part will forever be a problem, both for economic reasons and for the way the medical system is set up in terms of our confidence of the rigor behind science, and for the you know, the mere difficulty it is to get certain things published in a timely way, and where people will use what is being published as evidence, and usually it's not more than beyond a couple variants that you can hang your hat on from any given paper in terms of your confidence for what something may or may not mean. So I think that there are some societal, philosophical things that would have to change gear.
Get out.
Yeah.
Sorry,
no problem. My son's usually running around like crazy and all these things. So, but no, that's my 2 cents worth. But, yeah.
Well, if I could take that conversation a little bit further and expand it outside of the functional studies, one of the things that I've seen with respect to ACMG is more of a disease-specific focus, as opposed to the initially promulgated, you know, very rigid, this is the way you do the variant interpretation with ACMG. And now you're seeing a plethora of disease-specific focused modifications to the ACMG guidelines. So very similar to what we talked about with respect to functional studies being predicated on disease specificity. I wonder if the group can speak to what changes we're seeing to get more of a focus on disease-specific context for ACMG, and how that's going to play out when the goal of ACMG is to have a framework that can be abided by all. Now we're having these, you know, splinterings and ramifications where it's requiring increasing specialization within, you know, individual disease groups.
Yeah, I mean, I'll take a stab at that. I mean, if in terms of the ACMG had a pretty daunting task when this all started.
Oh, of course, clearly.
And they were in a position where, in many ways, they started off backwards, right? They just started off with a gene list before and genes that you reported back before necessarily defining how you define things are pathogenic and likely pathogenic. And it was a need. It was, you know, born out of the sequencing that was becoming mass scale. And when one dissects the ACMG, you look to see who are representatives of that body and who are medical geneticists that were part of that and what their disease-specific areas were, and what in a medical genetics clinic was defined as actionable, or in areas where there were things needed to be reported back as it may change to management, whether it be a connective tissue disease or a surgery required for some of the extreme cancer phenotypes, or an arrhythmia might present itself. So as time, I think, went on, and that became the reference for people in other disciplines, oncology, what have you, that were not typically, card-carrying members of the ACMG to start with. There has been an initial acknowledgement that was the appropriate place to start. That body has, through ClinGen and other efforts, integrated other colleges and societies. ASH is a perfect example of that, with Lucy Godley and her work leading the hematology efforts for classifying variants, and kind of a organic growth to all of this, as there are additional experts that are being pulled in. And with that process, there's been a whole lumping and splitting in terms of thinking about genes, thinking about disease, and then kind of getting in the more granular space of trying to define variants for all of these things through expert panels. So I think the ACMG started off in a very well, it was a broad focus, but with that said, it was still somewhat narrow in terms of the representation. And as time has gone by, there's been a broader scope of folks that have been brought into that, with that as a backdrop of how all this variant curation has evolved.
I'd be curious, Jamie, what you think about the future as a variant scientist or curator, as it's become more and more complex. How do you anticipate in the future variant curators or scientists being able to analyze germline data? Because if every gene has its own rules, how will you keep up with all that, or how do you imagine it will be?
Yeah, well, I think that's going to be one of the biggest challenges, and within the ClinGen efforts for most of our variant interpretation working groups, really the collation of data from the reference labs who are doing this, have all this internal data, has been our most important piece of evidence for variant classification. And, of course, as Mike said, some of our groups are using this functional data. I mean, in the TP53 working group, there are very well-established functional studies that we trust. In our CDH1 working group, we actually don't take functional data into consideration because it has not correlated with patient presentation. So really all of that, the breadth of standardization across all of the genes in the genome to try to figure out what pieces of evidence are useful with respect to variant interpretation, based on the known patient phenotypes, that's going to be the biggest challenge. And it is, the ClinGen efforts are kind of focusing on the highest profile, the most critical genes, LFS, CDH1, where there's real surgical and or surveillance implications, but expanding into those more moderate and lower penetrance genes and or variants is going to be very daunting. I'm not sure I answered Kim's question, but it's a challenge.
Well, and if I could just chime in too, as related to variant science, I think it's been really interesting to observe the evolution of jobs in the area of genetics, right? Like as a genetic counselor, it's really evolved. And 10 years ago, variant science, as we know it today, really didn't exist. So I'm still surprised in talking to many of the labs that are hiring variant scientists. they are pulling from PhDs, from genetic counselors, kind of converting them, and there's not really even an organization that I know of for variant scientists in general. So also standardizing training, because it's divided now among pathologists, geneticists. I don't know if anyone's really given thought, or Jamie, if that started to come up, like what will be the standard for training of variant scientists?
I don't think so. I mean, yeah, we have not discussed it at St. Jude because our operation in terms of variant scientists is very, very small. So 1 to 2 person operation. But I do think that that's very important, you know, because reference labs and our children's hospitals and everything do want standardization in what we are calling variants. And with, you know, I can interpret something completely different than the person sitting next to me. So right now, I think that there is becoming more standardization. A lot of curators are involved with the ClinGen efforts, which definitely does help having those conversations and seeing how these guidelines are formed. But I think it will be important in the future to have a society, some kind of more formalized training to get everybody on the same page.
Yeah, I think that's a nice point about the educational aspect of this, and almost a degree that could be had in all of that. Certainly, you know, when I got started in this space, so to speak, for 3 years, I just sat and looked at variants, and there was not necessarily any training. The ACMG rules around how to classify variants weren't there. I had a genetics background from formal, but wasn't specifically around molecular. And as this field has emerged, it's in some ways still gray in terms of who knows what and what people's responsibilities are in the space, and in terms of who should know what. To your point around variant scientists, because there are certainly discrepant resumes, so to speak, in terms of who's doing that, and that is a big problem.
The other thing, kind of in parallel to that, is just the classification system, that it still is the benign to pathogenic. You know, there's not a formal recognition of moderate penetrance or low penetrant alleles, and so I just think that will have to change at some point. Obviously, all these ClinGen efforts, but it just falls on people for the individual gene or the individual lab, or you might have to write out a paragraph describing the effect of that variant, but that's really so qualitative for something that should have more of a quantitative basis. And we know that it's so much more complex. You know, like Kim, you're talking about like all the different functions of a given gene. It is going to be different if all the functions are knocked out, or one of the 3 functions is knocked out, or that's varies so much. And I think it's hard to have a variant classification system that only reflects like a dichotomy of it is pathogenic or benign, and so I don't know the perfect solution. Like, I don't have a great solution for how to modify that because it's so complicated, but it has to be more complex in the formal guidelines than just those 2 options to have.
Yeah, I've heard about a movement toward more quantitation of the scoring as opposed to a dichotomization. Mm-hmm. And what I'm seeing in particular in terms of the disease-specific modifications is there's ways to take these categories of ACMG evidence, and even if they're strong, you can downgrade them to moderate or upgrade them to very strong. And so that does lend itself, as you said, at least, to more quantitative approach as opposed to just categorization. But that challenges standardization a great deal, and it makes it more complicated to ensure that interpreter A is interpreting the same variant in the same way as interpreter B, even when they're presented with the same information. So I feel like that's a very large challenge. And we talked about this a little bit with respect to ClinGen and ClinVar. I'm wondering if we as a group can talk about any challenges that are facing ClinGen and ClinVar and ways that the community can get behind them to break through those challenges.
Can I say something? Oh, go ahead.
I was just to add to the fact that I think whilst we're looking at the challenge in front of us, maybe we need to step back and just realize that really we have this balance between continuous improvements and learning, and that is led by standardization. But then there are these individual breakthroughs. Every generation brings 70 to 200 new variants. So to have a very structured, standardized model, just the subject matter that we're trying to evaluate breaks that norm. So I think whilst there needs to be guidelines, but even looking at a mutation, you have to look at it in the context of the person and the broader context of the genome. So I think that these are the kind of aspects that, and one where I do think, and it kind of goes into the question where we as a community, we often forget that the clinical knowledge and what we're seeing in front of us, that is going to be recorded into our EMR. How do we go back and learn from it? So I think that once we realize how to harness that and then build that into our continuous knowledge, that might be the way forward. Still has challenges, but
yeah,
it sidesteps us.
You basically have set the stage for exactly what I was going to say. And I'm not as involved in ClinGen or ClinVar as I probably should be. I just have too many things going on. But the thing is, I think it's really important, right? It's really important that the genomic data be looked at in context with the clinical information. And in my mind, one of the biggest challenges is bringing those two pieces of information together. I mean, Mike, you probably know about this, and this gets at what Elise said. I mean, there are some variants that are going to have a stronger phenotype than others, and phenotypes are going to vary. And how are we going to bring it together? And for Jamie, you know, in the variant curator or scientist field, you know, they probably come at it from more of a pathology or a computational angle, but understanding the clinical component. Like, I think what's really important is somehow having constant communication and a way to bring these disparate pieces of information together so that we can better understand what these variants are going to mean in the future. And if there's an answer for how to combine and continually build on the clinical in a way that helps interpret the germline, or the genomic, that's what's really going to be important moving forward. So I think this is a really challenging but important area. Mike, I'm not sure if you want to build on that. I mean, you've been so much more involved in this as a geneticist. I'm just a little old oncologist, but I'd be interested to know what you think.
Yeah, no, I know. The ClinGen part of it where it suffers is, well, I shouldn't say it suffers. I think where I'm chair of the somatic germline integration committee to try to help clarify germline variants utilizing somatic data. And like anything, it's resources, right? So we all have very good ideas about how to try to take next steps. And then rate limiting steps are getting clean data to integrate and having access to information from different centers, right? So with that said, there is good reason for certain centers to clean their data, have it, at a particular level. And I think that's something I've appreciated more as time has gone by with the two most recent centers I've been at, in the sense that there's this push, you free the data, but you don't want dirty data.
That's right.
So you want things annotated as well as humanly possible, whether that be the clinical part or the molecular part, and ideally it's both. So I think ClinGen, Sharon Plon, who leads, she's the godfather, so to speak, of all this stuff, that's the way I think of her, is very conscientious of all this and been in this game a long time, and I think has done a tremendous amount in terms of identifying players at different centers that can begin to really kind of move all of that together in a meaningful way. But there are I went back, I mentioned the economic part of it earlier. A lot of it's economics. So having the ability to have additional resources for bioinformatics and so on is always a rate limiting step for all of this. And then MTAs to share the clean data when it's available can be a rather drawn out process. So those are just a couple practical things, but they're things that can actually expedite matters quite a bit if in place.
Mark, I was wondering if you could comment. I was just thinking during this conversation just about the role, and I know this is kind of a topic we wanted to discuss, of like AI and machine learning, because that's what I'm hearing a lot of when we're thinking about the clinical correlation and just design of products that can really use the machine learning concept to pull that clinical phenotypic information together with the molecular. So I don't know, Mark, if you have thoughts or other people have thoughts on initiatives at their own centers to do that.
Yeah, I'll start by saying that you should always be, as clinicians, be armed with evidence. So Genomenon does not think of AI as a black box solution to any of these problems. I think that it's a tool to arm the clinician with the best evidence and to continue to leave the decision making in the hands of trained clinicians for all of these nuances that we talked about. You know, clinical context, the challenge of these disease-specific diagnoses, just the nature of the complexity of the data. And so I very much think of AI as a way to organize evidence for decision support. I don't know that we as a community ever want to get to a place where AI can be a stand-in for any of these clinical decisions. And so obviously, particularly at Genomenon, we surface information from the medical literature and keep that as up to date as possible. But the idea is always that it be organized, that it be as sensitive as possible and as organized as it can be, but then the ultimate onus of decision making is on the clinician. So I wonder if anybody else is more optimistic about AI, you know, taking over. I'm not. In my training in pathology, I was always very pessimistic about the idea that these tools would replace the human touch.
I think, I don't know that I have the answer to that, but I think one thing this brings up for me is that it's important, I think, to think about how we enter our molecular data into the electronic medical record. With our most recent assays, we were actually able to interface our results directly into the EMR so that we have discrete variants that are now searchable, which I think for us was a huge celebration and victory because now we can actually tie that data to particular patients and particular demographics, but that's still not perfect either. And I think, you know, that's something we really need to think about. How do we make that better? How do we enter our molecular data into the electronic medical record in a way that makes it useful for all kinds of different things, for this interpretation, for submitting data to consortia, to utilizing that data to talk to payers about, now I can put together this set of patients where this test was really impactful. So I think organizing our data and interfacing that with the electronic medical record is going to be one of the first steps to making this kind of AI and decision tools really valuable.
And if I could add to that, because again, and I think, Liz, you mentioned that I think we need to evaluate the role of clinical labs in this journey, and we have to recognize that we're not at the end. So whilst we're entering and interfacing the genetic and genomic data, that was born out of a subset, and I think we mentioned very early on that as our knowledge is growing, rather than having these very discrete panels, we know that we're generating a much larger data set, and we have the pressures of the payers that we cannot do exploratory panel research, but the lab is actually generating that data. So how do you link that larger body of data with the EMR that if you have what I call an unsatisfactory diagnosis, there are VUSs in there, can we go back and ping that data in a very streamlined fashion, rather than, pump the brakes, let's sit down, pull this data set, pull that data set, and can it happen in a more streamlined fashion?
Lisa, you brought up something that I wanted to touch on for sure, is the specter of, with all this, proliferation of new information, with modifications to the decision making and these voices in otherwise undiagnosed patients. How does the panel think about the look back challenge of, you have a case that remained undiagnosed? How are we going? I mean, Michael, you're bringing up this pragmatic challenge. Who's got time for this? Who's got the resources? Let alone, how do we communicate this information to the patient? So if anybody has ideas about what you're doing at your institutions to solve this look back challenge of cases that haven't been diagnosed, but that kind of demand for the clinical circumstance a revisitation of that data in light of any new published information.
I mean, I think, like, from at our perspective at St. Jude, I mean, it really behooves the provider to go back to the lab to ask for a reanalysis. I'm not sure how it works at other places. I'm worried that from a laboratory perspective, it's going to be too challenging or overwhelming to go back and look at every single case that's been tested over the prior years. There will be hundreds to thousands of cases. At our institution, it's been up to the genetic counselor or the provider to ask for reanalysis every couple of years, as needed. And lo and behold, just like I'm sure for all of you, I mean, we've come up with new diagnoses as new data has come on board. I mean, I'd be interested to know if others feel differently, but it's worked for us, but you have to educate the providers that they will need to reach back out. I mean, the question, I guess, will be economics. I mean, I don't know if it is something that the provider would need to pay for again, or if that can be done, at a reduced cost or free for service. I can't recall. I think for our patients, the companies that provided the broader sequencing at the time, did the reanalysis either for free or for a reduced cost. I don't recall, but I'd be curious to know what others do or suggest.
I mean, one thing that I found helpful when working with Genomenon and interfacing with labs is just learning about their different operations. And when you think about some of these tertiary analytic platforms that are now kind of prioritizing variants, and then also other AI-based tools where you have updated literature, I'm wondering how much can be more AI-based for the look back, or at least present to the clinician, like, here's the updated, like, here in the last year, here's the new information about this variant that's been reported, so that then it helps the clinician to triage that look back process. Or, I just think the only way to do it is some kind of automated supplement to that process with still the human element of discernment.
Right.
But I haven't really come across anyone who's optimized that process, but I'm curious to know if anybody else is aware.
Well, I also think that there is a power of the patient, and the patient has a voice here as well, and there's a huge educational component. Again, when we go into surgery, it's a very finite, we know exactly what it is, whereas when they're entering and getting the genomic testing, this is a journey, and they have to understand that today's result doesn't mean that it's going to be the same tomorrow. And so having discussions on multiple levels, I think, will start help guiding us to what that process looks like. And as always, just like with our iPhones, some people, track me, I don't care. And some people will make sure that everything and kind of aluminium hat is on their head. So I think we have to be very sensitive to those aspects as well.
Yeah, I don't think we've optimized it either, but I think it is very patient dependent, because the way that we have it, I think the way that most people have it is that the patient has to kind of reach back out to us for clinical updates. If it's part of a research protocol like our MSK impact assay, then potentially there could be updates, but that patient is signed on to the research protocol, and so if we find something and then are not able to recontact the patient, we can't track them down, the phones are not in use, then, you know, we have a protocol for how to deal with that. But I think everyone's really nervous to take that responsibility on clinically, like in addition to the huge workload that is. It's just a lot of liability. It's not a perfect world where you can find everyone who you could find 2.5 years ago. So I think that it is very patient driven, and that also allows patients to kind of dictate the importance of it, because it's just not worth our work. If they're not interested, they're not going to follow up regardless of what we contact them with. And there's some patients who really, really have something, and we know they have something, and they know they have something, and we're all frustrated that we don't get to it with the first test. And then there are other patients who we send the same testing on, but they probably don't have a predisposition, and you know, the negative or kind of unlikely VUSs are reassuring to them, and that's probably fine if they don't recontact us, or you know, if they reach out in like 5 years instead of 1 or 2. So we just try to emphasize it to all patients, but we're not doing anything clinically like on our end without them reaching out.
I wonder in the last few moments if we can build on what Elisa and Elise said about patients and their intrinsic motivations and their understanding. I'm just wondering how well educated they are in light of, you know, direct-to-consumer genomics. How receptive are they to these new lines of evidence, and how has that influenced your clinical practice? Or has it not changed at all?
I mean, as Elise was talking, one thing I was thinking about is health literacy barriers and just diversity and access barriers, because
that's where my mind went to.
Incredibly disparate. And so that's also a concern of mine, is that if it is left to the patient, even though that can be very positive, due to barriers that some patients have over others, that could actually lead to a lot of inequity.
Yeah, I agree. Completely not.
And I also think that, I mean, that is obviously a problem, but, you know, Liz, I would imagine, you know, even people who don't necessarily have those barriers. Now, I don't know as much about direct-to-consumer testing, but, you know, some of those tests are very specific variants in a gene, right? And they get a negative test and they think that they don't have any variants in the gene, you know, they think they're okay. Right. And so I think, you know, this just emphasizes again for all you genetic counselors, I mean, how critical it is to do genetic testing in the context of genetic counseling. And I mean, personally, I feel like it's a real disservice to do genetic testing without genetic counseling, both pre-test counseling and then post-test counseling. And you know, I feel like we're lucky in pediatrics and at St. Jude. I mean, we often can see patients, because ours have cancer, we can see them periodically afterwards to continue to educate the families, but it's very different perhaps with other diseases and in the real world. So I just think the counseling is really critical across the board.
Yeah, you find often providers don't have a clue about a lot of this. Never mind, people were trying to explain it. So
right, you are. Right, you are. We have to cancel everyone.
The tricky space. So,
great. Garrett, I'll pass it over to you for any closing remarks.
I was going to say, in the interest of time, I think, you know, but I wanted everyone to have a chance to give, you know, their final thoughts. I just want to thank all of our panelists for, you know, taking the time to offer your expertise in this roundtable. I think we had a fabulous conversation. It seemed to move itself. You all had a lot of great feedback, and you had some really good conversation chemistry. So I think it was very valuable. So I do thank you for that. So.
Yes, thank you all.
And I will close out with our ending slide here. So for everyone watching, thank you for tuning in. And to all of our panelists, thank you for taking the time to offer both your expertise and your time in this roundtable. If you have any questions or would like to discuss your variant interpretation needs, feel free to send an email to our folks at hello@genomenon.com. Additionally, if you don't already have a Mastermind account, you can create one for free and receive a free trial of Mastermind Pro. Last but not least, your feedback is very important to us, and we'd love to hear your thoughts on today's webinar. At the conclusion of this event, you'll be prompted to take a brief survey that will help us as we continue to create a highly valuable customer experience. So with that, thank you so much for your contributions and interactions, everyone. I think we had a great conversation.